and welcome to another Pipe at Pearl. Today's Pearl, we're going to look at men's health and in particular scrotal and penile pain profiles. Men's health can be quite difficult to conduct a consultation on, mostly because men don't often like presenting to outpatients departments. They have a lot of stigma associated with them seeking help for care. The goal of today is to introduce a few statistics that most people probably aren't aware of with men's health because it's quite often not spoken about, and then focus on complaints that are obviously isolated to them, which involves disorders of the scrotum and the penis itself. Now, whilst STIs is a common cause of these problems, we're not going to focus on them today as we've already covered them under this area. So starting off, let's just have a quick look at an overview of a few statistics and some surprising findings on men's health and use that information to guide us in providing a better consultation. So overall, men are more likely to die in every age group. It doesn't matter which way you split the age groups, men are more likely to die than females are. And this has been the case since they started collecting data back in 1900. So in 1900, they started to collect the average life expectancy and where people died associated with age. And even though the life expectancy back in 1900 was 50 and 55 respectively, there has been a 5-year difference between male and female consistently since the 1900. So now the current life expectancy for men is 81 years compared to females, which is 86 years. But if you look at any age group, men are more likely to die than women. When we look at work-related deaths, so that means any death that occurs directly as a result of the man's work or whilst the man is at work, 96% of all the deaths that occur at work are associated with men. So all your workplace accidents, I won't say all, but 96% of your workplace accidents, workplace incidences resulting in death, you're obviously more likely to die on the battlefield as well, which is included in those statistics, so 96%. The risks associated with men's life, when they're at a younger age, it's more likely to be accidents related. They take much greater risks with their own life, and as a result of that, they end up dying as a result of accidents, motor vehicle accidents, diving accidents, things associated with sports, that sort of stuff. They're more likely to die at a younger age. They're not all, but a lot of them are built up in a society where their life is more expendable, which sometimes leads to the stigma that they're able to take more risks. And also, we can't ignore the bravado that is associated with being a male, and obviously that comes with the inherent risk. As they get slightly older, we're talking 25 to 45, there are higher risks of suicide. And this is often associated with life partners, marriage breakdowns, loss of job, loss of identity, that sort of thing. They end up committing suicide. As they move on in life, it's their lifestyle that really takes a toll on them, and that includes tobacco, obesity, diet in general, alcohol, and drugs. There was a statistic that said only 4% of men are actually getting the required nutrition that their body needs in the areas that the data was taken from, which was the Western worlds. So that's pretty alarming. Now, don't get me wrong, the females weren't too much better. They were sitting around the 11%, okay, but in comparison, 4% for men were getting the actual diet they need. And the prolific use of tobacco, alcohol, and drugs was higher in men compared to women. When it comes to terminal illnesses or diseases that are going to be long-term or chronic, men are more likely to die from those diseases early, resulting in that premature death. So men are more likely to die prematurely as a result of a illness than their female counterparts. There's a few theories associated with this, but obviously every case is slightly different, but men statistically tend to have a lot more emphasis on being useful. That they put usefulness over being wanted. So being wanted is always nice, but generally speaking, men feel the need to be needed. So in the event they are no longer needed due to injury or illness and have to be cared for, so they lose that independence, they lose that autonomy, if you will, then they're more likely to give up on a chronic condition, less likely to do the actual treatment regimes. And they say that 40% of these premature deaths could have been avoided with the correct treatment and lifestyle changes, which is pretty alarming when you think about it. Not surprised to anyone in the health industry, but men are also less likely to seek help for their general health, and definitely less likely to seek help associated with mental health. There is a requirement in societies, regardless of how many people want to deny it, that men do need to be resilient and they do need to be stoic. Now, when you look at our line of work, that is definitely the case. Everybody needs to be resilient and everybody needs to be stoic. But the fact that our workplace consists of 85% men just means that statistically more have to meet that requirement. And with that requirement comes the stigma and the almost paradigm condition where how do you seek help when you're supposed to be able to push through, supposed to be able to soldier on? How do these conflicting messages actually get through in order to give the men the help that they need? And that leads us to the final question. So we know these points are pretty poor. We know all these variables and stigma come into play. But what do we do as clinicians? What can we do about all this, apart from education, which a lot of men know? Okay? There's not many people out there now that know smoking is bad for you. So it's not a revolution when you bring that sort of thing out. Over drinking is also bad for you. Shocker, I know, thank God you're sitting down. So it's very difficult to just educate these people. So when you're dealing with men consultation, it's best to take every situation as serious as you can and also statistically look for hidden problems that the man may not be presenting. May be presenting with a problem, may not be telling the entire problem. So try to create an environment in which they can share. And in the event you are going to treat them and offer restrictions, things like that, just remember their often pathological need to be useful, and just realize that sometimes removing them completely from a workplace can actually be more detrimental than not. Not in every case, some people need a break, okay, but statistically men are more likely to get worse if they're put in a corner and not being useful. Okay, moving on from the general men's health, we'll move into a little bit of epidemiology associated with scrotal and penile disorders. And then if a man presents with these ones, you can at least give them a proper consultation, but always have that in the background, thinking of what else could be going on in this person's life. So scrotal pathology should always be considered when a man comes in with abdominal pain. So problems with the scrotum often refers to the abdomen as pain. When we look at scrotal problems, they can be broken down into three main areas. We've got our ischemic and traumatic, so obviously excluding direct trauma. We've got torsions of the testes, hematomas, and your hernias. When we look at our infection, we're dealing pretty much solely with epididymitis and epidiorchitis, which is inflammation of the epididymis and the testicle itself. Neuropathy is also known as referred pain, and that can be done through mild dural stones. Hernias can as well, nerve entrapment, and then certain smaller vessel aneurysms can also cause this referred pain. When you're looking at a profile of scrotal pain, 25 seems to be the magic number, not solely, not saying that anybody outside of the age range can't get it, but it definitely is far more prevalent in people in this age group. So if you're under the age of 25, then you're more likely to get testicular torsion. And we're talking about 1 in every 160 men will experience rheumatic cord torsion within the first 25 years of their life. It is possible after that, but the probability drops dramatically. As you get older, over the age of 25 and beyond, then epididymitis is the most common cause of acute scrotal pain. Okay, so just be aware of that. That occurs in 1 in every 140 odd people who visit outpatient departments. If people ever mention blue balls as a cause of a pain, then epididymal hypertension is a thing. Okay, it is a result of heightened arousal in the absence of climax. Okay, so it does actually occur. It's theorized to be a result of an increase in blood flow and pressure, obviously hypertension, that goes on too long. The point of orgasm, then all the blood is essentially released from the organ and the pressure and the discomfort goes away. Blue balls or epididymal hypertension is a thing that occurs in both males. Females have a similar condition. Okay, it's often blue vulva or blue bean is often what is colloquially called. Obviously, it doesn't involve the epididymal region, but it's a similar phenomenon of blood entrapment in the absence of a climax. Just because a climax is often the thing that relieves this discomfort does not automatically mean that sex is required to prevent or cure it, because simple masturbation can relieve the pain yourself. When we move from scrotal areas and we look at penile disorders, obviously the most common cause of penile disorders is our STIs, but anything else outside of that will involve the foreskin. So a lot of the disorders that we're going to talk about today is associated with the foreskin. So it does require observations during our consultation. Okay, so just so we're all on the same page, we'll have a quick talk about the pathology of those common disorders. Testicular torsion, epididymitis, and balanitis are the three that we will focus on. And just a quick overview of the pathophysiology. So spermatic cord torsion may be intravaginally or extravaginal in nature. Now, I understand that term may be confusing for those that haven't read a lot of anatomy literature. It's often associated with the female, but it basically means internal versus external. So when we look at that extravaginally torsion, it's pretty much exclusive to neonates. So we're unlikely to see it in anybody else that's not a neonate. And it's caused by the more fluid nature and mobility of the testicle before it descends into the scrotum. But during the intravaginal torsion, it's frequently associated with a deformity known as Bell's clappers, and that occurs in about 12% of men. So Bell's clappers deformity pretty much twists the testicle on a different angle, making it more susceptible to twisting. And the somatic cord twists on itself, ultimately pinching off the arterial blood supply and the testicle, leading to ischemia and infarction if it doesn't get treated. The degree of torsion may vary, but when we're dealing with occlusion and congestion, then it's often 180 degrees. Most cases of spermatic cord torsion leading to infarction is a twist of at least 720 degrees. When we look at epididymitis, it's a genitourinary tract infection. It's usually due to the continuous spread of a pathology from an affected bladder or urethra. So in the event you have urethritis, cystitis as a male and you don't treat it accordingly or quickly, then it spreads to epididymitis, pretty much the same way that in females it spreads to pelvic inflammatory disease. Now, another age group is interesting to note that any male that's less than 35 years of age, it's most commonly caused by sexually transmitted organisms like chlamydia, sometimes gonorrhea. Not exclusively, but that tends to be the age. Men over 35 years of age are more likely to get it from uterine or gram-negative urinary pathology, like your E. coli. Now, other pathogens can be the cause, but that's generally the way that it works. When we move away from scrotal disorders and we move to balanitis itself, it is the most common condition found in uncircumcised males involving the penis, and it's often due to poor hygiene the accumulation of smegma beneath the foreskin. Smegma itself is a whitish sebaceous secretion that comprises of epithelial cells and sebum, which is obviously the oily secretion similar to the skin. The production of this semen, smegma, is associated with the sebaceous gland, and it's often associated with males, but it does also get created by females as well. It's often what is denoted as vaginal discharge. Under normal circumstances, smegma aids in the lubrication and the movement of the foreskin without friction or irritation as a result. In the event poor hygiene or a tight foreskin, a build-up of smegma, it serves as a housing point for bacteria and most commonly fungal overgrowth that leads to irritation and inflammation. So balanitis itself is an infection of the gland of the penis. Now, whilst it's most commonly caused by infection, and fungal candida is the most common, it can sometimes be caused by dermatological problems like psoriasis and allergic reactions, and very rarely malignancies. So if it looks a little bit weird and it's not associated with hygiene, referral is often best to specialists like dermatologists or urologists themselves. Okay, let's move into the consultation of our patient. So we'll start with subjective investigation, and it can pretty much be done in one slide. So the entire EPSAN can be done in one slide because it's a very focused area, if you will. Now, first thing we need to know about the event is the onset and the duration of the symptoms and the symptoms list. Onset and duration will generally tell us how bad it is and lead us to things more associated with testicular torsion versus a foreskin-based disorder that is actually causing a restriction in blood flow as well. Okay, so it often leads to the acuteness. If someone's only had this pain for, let's say, less than an hour, then they really come directly to it as soon as the pain started. They've come directly to the clinic in order to seek help. If it's a couple of days and they've been sort of feeling discomfort, then we can lead down more of that transfer of infectious type and other type disorders. Okay, now we need to know the symptom list because these things can be caused by infections, which means if they go on long enough, they can cause other symptoms and somatic symptoms at that as well. So we need to know what sort of pain the person's feeling, if it's associated with urination or felt in the abdomen, felt in the scrotum itself, in the legs, associated redness that the patient had noticed, any swelling of any particular part the patient's noticed, have they noticed a fever, and have they noticed any discharge. Now, discharge can be obviously pus or smegma, or it can also be blood in the semen as well, which they can tell us if they've ejaculated. Now, when we talk about past history, we really need to know if the person's had testicular torsion in the past. If they have, then they may have that bell clapper's deformity, which means they're more likely to have testicular torsion again. We also need to know whether or not they're circumcised, because if they are circumcised, then they're less likely to get balanitis, and they obviously can't get any disorder of the foreskin. Because it's closely linked to sexual transmitted diseases, we need to know their sexual health generally, and we need to know any STI history as well, knowing that a bunch of the STIs can in fact be asymptomatic. Physical activity, a real increase in physical activity can actually lead to testicular torsion, but heavy lifting, heavy bearing down can obviously precede any herniation as well. So inguinal hernias can also be a cause of scrotal pain. And if they're not reduced, then it can stop the venous and arterial flow of the testicle, which results in ischemia as well. You need to know if the person's been outfield or been in an environment where it's difficult to maintain hygiene, because obviously anything associated with the penile end and the foreskin is often heavily linked to that hygiene as well. As far as subjective questioning, we can go in a little bit more detail and do a better pain profile. If their main complaint is pain, you can do a PQRST in order to narrow down what sort of pain profile they're feeling. And you can also ask specific questions about discharge, as in when is it noticed, when is it at its peak, any associated smell, that sort of thing. Allergies and medications need to be asked because you need to know if they're allergic to any antibiotics in particular or antifungals. And obviously we need to know what sort of medication they're on to build a profile of what you can or should give them. Remember that, like females and candidate infections, if a person's been on antibiotics recently, then it just means that it's more likely to be a fungal infection underneath the foreskin. Moving on to our objective investigations, we start with vital signs. These disorders can spread to cellulitis. Cellulitis can spread to sepsis, so we need to check. Any associated fever obviously ups the ante, and we treat it as sepsis if it needs to be. In this particular case, we need to inspect the area. Okay, we need to at least inspect the area. Really need to explain to the patient the importance of doing so, because there's particular disorders that are easy to see, hard to describe, and if you see them, then they're associated with a medical emergency and need rapid evacuation. So we need to inspect the abdomen, the groin, the penis, and the scrotum. We need to note the problems associated with it. So we want to know anything about the region. We're talking rashes, ulcers, signs of cellulitis, testicular positioning, and obviously we need to focus on the gland itself. We need to know whether balanitis is there. We need to know the position of the foreskin. If the foreskin is over the top of the gland, then it needs to be retracted in order to see that it can occur without pain, and also to see the gland for redness. Now, in some cases, these conditions can get so bad and quite chronic that you'll actually get adhesion of the foreskin to the gland. So congenital adhesions can occur. This is when the inside of the foreskin is attached to the gland, and that's more like skin. In this case, it's caused by fibrosis buildup and fibrosis formation, which means it's connected itself to the gland, meaning retraction is painful and sometimes impossible, obviously. Now, when you're evaluating the gland and you're looking at balanitis, which is infection of the gland, you need to know whether or not it involves the foreskin. So people who are circumcised can get balanitis, but people who haven't had the circumcision are more subject to infections of the foreskin called phimosis and paraphimosis. So phimosis is the disorder where it's inflammation of the foreskin. Paraphimosis is a medical emergency. It's where the foreskin is in fact trapped behind the gland and cannot be pulled back over in uncircumcised men. Okay? And this requires an urgent urological consult. Okay, so it's actually considered quite an emergency. As far as palpation goes, play it by ear, much the same as any invasive procedure that involves the genitals. It can be helpful to palpate, but you can also ask the patient if they're palpated for certain signs. So play it by ear, either do it yourself, ask the patient to do it, refer it on. It all depends on environment and how much you believe is testicular torsion and whether or not you want extra evidence of susceptibility. So always get the consent. You can ask the patient if they've felt any masses, and if not, it can lead to obviously how to do a self-check of the testicles. There's certain signs associated with testicular torsion, and it's often associated with high-riding asymmetrical testicles. So it can be normal for the left testicle to be slightly higher, but in torsion of the testes, it's quite marked, high-riding and asymmetrical. So one testicle will be quite low compared to the other. There are certain signs that have been notated in literature. So friend sign is associated with lifting the testicles. Okay, so if you lift the testicles and there is pain relief, then it suggests that it's more likely to be epididymitis. Whereas if you lift it and there's no pain relief, then it's more suggestive to be testicular torsion. Okay, as far as cremasteric sign goes, that's associated with the cremasteric muscle in the thigh. And the idea of it is the cremasteric reflex is done where you rub the inside of the thigh, and what happens in a normal case is the testicles will lead or be pulled to that side of the thigh that you're working on. Now, this is a very fickle test, and it may be absent in 30% of males without any pathology whatsoever. Okay, and it can also be a positive sign in people that have testicular torsion. So whilst it is a sign, you will read it, you will read about it, it's not the be all and end all. So you can do it, and with the associated high rising pain profile, friend sign, and a negative cremasteric reflex, then sure, you build a profile associated with testicular torsion. However, if you have all those other signs and you still believe it's testicular torsion, then the absence of these don't actually make it a absolute negative. Okay, so just keep that in mind, and ultrasound is considered the most useful. Pathology can be useful because of the associated infections, but ultrasound is ultimately needed if you really want to diagnose testicular torsion. So when you have all the data, we move into our assessment, and the assessments involve really finding out whether or not it's a medical emergency, first of all. So testicular torsion, if that's suspected, then it's a medical emergency. You have a small window of success. Okay, you want to be able to relieve that testicular torsion as early as possible in order to prevent testicular death. The problem is you don't know whether or not it's full occlusion just by looking at it, so you don't actually know what your time frame is. So the classic cutoff for salvaging testicular torsion is generally within 6 hours of onset of symptoms. Okay, now that doesn't mean that if you lose the 6 hours and they're 100% gone, but the salvage rate does drop about 85% at 12 hours, and a further 31% at the 24-hour mark. So you really got to get it in as early as possible. If you've got full occlusion, then obviously you've got less time, and that 6 hours is the benchmark. As mentioned before, paraphimosis on visual is also an emergency that needs consultation. You will not be able to pull it back over the actual gland. You can try, but it has a very, very low success rate. It can happen as a result of you forcing a retraction back over a very tight foreskin, so just keep that in mind, that if you are retracting in order to have a good look at the gland and it is very difficult, then you may in fact cause the foreskin to be stuck behind the gland, causing paraphimosis itself. So just always keep that one in mind. If it's not torsion of the testes, then it can be STI causing epididymitis, epididyorchitis. It can be a hernia, and it can be a mass of unknown origin. So you can find a lesion, ulcer, whatever it is on the testicle. You won't know what that is until it goes on to further investigation. I'll be doing a separate lesson on testicular checking and probability of findings to follow, so have a look out for that one in your patient examination areas. If it's not balanitis or paraphimosis, then it can be associated STIs. It may also be a myriad of smaller infectious-based disorders or ulcer-based disorders, genital warts, or even normal small papules that you'll find at the end of the gland that young males are often worried about because they just haven't seen it before as they go into that heightened end of maturity. Okay, so if it's small little white papules at the end of the gland, completely normal. They're just the glands that produce the actual sebum that goes into the smegma, and sometimes they can just get enlarged, but there's nothing to worry about. Now, these particular cases, especially scrotal pain that isn't suspected testicular torsion, have a very high rate of absence of diagnosis on first presentations. Okay, so don't feel too bad if you don't know the exact answer on first presentation, as it often takes ultrasounds pathology in order to get the correct answer. Moving on to treatment, We'll start with treatment of scrotal pain. As far as education goes, it's really case dependent. Okay, it can include tips on physical training. If you haven't physically trained for a significant period of time and you move into high-end physical activity, then it can be associated with testicular pain. Bike riding, when you're not quite used to it, is another one. Obviously, horse riding as well. Educate the patient on how to do self-checks in order to maintain testicular health and denote any problems that could occur nice and early. Treatment of testicular caution can involve manual rotation, but that needs to be done by trained clinicians. Okay? It's often done medially to laterally as statistics go, and you can need to do it up to 720 degrees before they can get relief. But as mentioned, trained clinicians can do that, and it's often on surgical consult that it is tried before going into surgery. Treatment for epididymitis involves your ceftriaxone first up with 500 milligrams stat, and then you move into azithromycin, 1 gram, and then 1 gram every week thereafter. If you can't do every week, then you give them a 14-day course of doxycycline. Now, this is obviously on consultation before you hand out these antibiotics. Restrictions can be associated with physical restrictions. Okay, you may need to, in fact, stop them doing the heavy lifting, especially if there's risk of inguinal herniation or something like that. And work-related, depending on the physicality of their job, it can be difficult to do with epididymitis. So take that into account and give them restrictions to support their recovery. As far as referrals go, in reality, most cases of scrotal pain will result in some sort of referral. In the case that it is epididymitis, it can also need to be referred because it can be associated with an STI. So until the actual screens come back, you will need to take samples, blood samples, or to try to get the pathogen origin. And if it is associated with an STI, then obviously you have that contact tracing. The treatment for penile disorders is obviously different. This is where education on hygiene is at its peak. So hygiene for people, men, with foreskins is paramount. It is absolutely paramount for prevention. The patient should be doing it at least daily, regardless of the environment, and should retract the foreskin every time. Okay, so a good tip for young players, if they have a foreskin, is every time they go to urinate, they should retract the foreskin fully rearward before urinating. Okay, that way they are actually exposing it, stopping the buildup of smegma. If on urination and visual cue they see an increase in smegma, then it should be cleaned off each time instead of waiting till the end of the day. Okay, and that's for prevention. If they have balanitis or they have a foreskin disorder, then they need to clean it associated with the treatment. But sometimes using lots and lots of soap can be irritating. That just worsens things like balanitis. So using soap once a day is fine, and using water or wipes or anything like that for the rest of the day is perfectly fine. The most common treatment for balanitis is your antifungal, and you use clotrimazole 1% BID, similar to obviously female Candida. Okay, so in the case if someone does have balanitis, the direct partner will need to be informed and obviously checked, sometimes just treated for Candida-based infections as well. Associated restrictions can be given if hygiene is very difficult in a particular area, and also for comfort. Certain clothing, certain items that they have to wear can be uncomfortable, so sometimes restrictions, alleviating them for that discomfort can be a good idea. Referral, anything really abnormal, any bad case of paraphimosis, any inflammation, any associated cellulitis, anything that you're looking at and don't quite understand what it is, and obviously in the event of foreskin strangulation is an immediate referral. Okay, so that brings us to the end of men's health in general and scrotal and penile disorders. It can be quite a difficult consultation. It is almost mandatory to have a visual inspection in this case. Okay, females can generally get away without a direct inspection by yourself on first presentation, but the associated risk of disorders causing ischemia is too great for visual inspection not to occur. So explain that to the patient. Palpation is a case by case, but inspection is a must. And also, in note, whenever you're treating a male who comes into the clinic, it's going to be a general rule for everybody, but in particular for males, always have that underlying feeling, turn your spider senses on if you will, for something else that could be happening, and take the opportunity to provide reassurance and education that seeking help for any health-related disorder can in fact make them more useful and less likely to be debilitated from a condition. But until next time, take care.